I'd like to thank the organizers of this meeting, particularly Agarwal and Deshpande, bringing me back to Pune. I thought I would focus mainly on the new ACE guideline because it has just come out. And it has some somewhat controversial areas that I think would be very nice to discuss. And one of the title that is given in the program is it worth having guidelines? And so I borrowed a slide from Dr. Perez about guidelines. What are guidelines? And guidelines are statements that make recommendations to help us. They're not some kind of religion or, we need to be a little cautious about them. At the same time, they're very helpful. But we need to realize what they are. They are usually written by a multidisciplinary expert panel. They review the literature, they rate the evidence and the strength of the recommendations. When you look at a guideline that has that, it has some benefit. And the process needs to be fairly transparent, avoiding conflicts of interest, but sometimes that may not be totally possible. And you also need to consider patient subgroups, patient preferences, and discuss alternatives. And then come up with a plan for managing patients. And I hope that we can use this in the context of what we've discussed today. Now, I'm going through the slides of the ACE guideline. It is on the ACE website. Many of you are members. You can download it, or if not yet, it will be available very soon. So, what we're addressing is atherosclerotic cardiovascular disease. And what we need to do is, first of all, identify risk in an individual patient. I don't know why the slides are moving by themselves. Anyway, I'll try to get a little back when I need to. So the first thing to do when you see a patient is to identify the risk factors and develop a personalized approach to evaluating risk and then optimizing therapy in that risk. And I don't think anybody would argue with that. It is grade A, although it's not based on any clinical trial. So what are the major cardiovascular risk factors that we have? Lipids are very much there. You heard about the use of non-HDL cholesterol, which is evolving and becoming quite popular right now, at least being pushed by various organizations. But clearly, LDL cholesterol remains as a major treatment target. You heard about low HDL, and of course, we're discussing diabetes at this meeting. And another important risk factor is chronic kidney disease, which is very challenging in terms of cardiovascular disease. And then on top of that, you go into obesity and a few other things that we don't often measure in practice, such as ApoB, small dense LDL. And then finally, the non-traditional risk factors, where the data still doesn't exist as to what value there is in treating them, although one or two may be important. Inflammation has been an interest of many of us. There are still ongoing clinical trials looking at inflammatory markers. The statins clearly lower inflammation, which may be part of the reason for using them over and above just the LDL lowering effect. Lp(a) may be very important in people from Asia. They tend to have higher Lp(a) levels. And now you have therapies such as PCSK9 inhibitors that lower them, although niacin lowers Lp(a), and as you heard earlier, it doesn't have that much of a beneficial effect. So we clearly need to look at the traditional major risk factors when evaluating risk, and also the additional ones. And then sometimes to refine the risk equation, look at the non-traditional risk factors. So very often we are using data from large clinical and epidemiological trials such as Framingham. The problem with that is the Framingham risk engine applies to the type of people who are in Framingham. I can bet you don't have many of them here in Pune. And the same applies in many parts of the United States. The Framingham equation doesn't always work. Recently, there have been a few others that have been added on, like UK PDS risk engine. We are developing one based on the Accord study result, and I think it seems to beat some of these others in terms of its predictive value. The MESA studies recently got a lot of attention where they're looking at coronary artery risk score, calcification, which has an advantage of being non-invasive, and has a good negative predictive value, but the positive predictive value in people with diabetes is somewhat challenging. Now you've heard about HDL, so I won't go into that. And I want to have a differing view from what Dr. Shah mentioned on triglyceride. Like HDL, it's a very good predictor of future risk. It's good for defining prognosis. But lowering triglyceride has been somewhat disappointing in the era of statins, on top of statins. So just as you have a negative trial with niacin, with AIM-HI, we also had somewhat disappointing results with the ACCORD trial, as well as with the fetus study. So, should we be identifying subclinical CVD with other tools, as in the MESA study, and looking at things like coronary artery calcification? And this has come out in the guideline as a recommendation, although it's not widely available. And what it shows is that a very high coronary artery score is associated with an increased risk. I find great value in a low coronary artery score. So if you have low coronary calcification, your risk of a future event, despite having other risk factors, is extremely low. So it's a very good negative predictive value. So one recent change that has been made in the ACE guideline is to classify people as at one extreme, which is very easy, low risk, and moderate and high risk. Not very difficult to do, but look at people who have very high risk, such as those who have recent acute coronary syndrome, established cardiovascular disease, or stage 3 or 4 CKD, etc. And the 10-year risk in these people is greater than 40%. A very new category that we define is extreme risk, and that is people who, despite current therapy and getting their LDL down to less than 70, and I'm using milligrams per deciliter, they continue to have hospitalization for coronary events, acute coronary syndromes, occasionally additional heart attacks. These people are very high risk for that. And now there's data to suggest that lower goals may be much better for them. Now I'll get back to that. So this is a new category. It was somewhat controversial. As you know, the American Heart Association and ACC a few years ago cut back on trying to get us away from having a goal. So no goal less than 70 or no goal less than 100. I think it was a very retrograde step. The ADA resisted for a while of getting away from the goals of 70 or 100, and ACE is taking the step now in a different direction. And I understand that the ACC is also looking at this based on the results of the improvement and some of the PCSK9 trials. And I'll keep coming back to that. So, what are the risk characteristics based on these studies? We now have these multiple risk categories, and I want to focus particularly on the high risk and extreme risk patients and what to do about them later in my talk. One of the questions that keeps coming up is, what about people with type 1 diabetes? Do they have the same risk as people with type 2 diabetes? And here we feel that you have to go by a number of additional factors. One of them is the age of the patient. So people who develop type 1 diabetes at a later age, those over 30, have much higher risk. And another very good predictor in patients with type 1 diabetes is the presence of albuminuria, as I'll show you in the next slide, as well as the presence of other features that suggest maybe insulin resistance, high insulin requirements, central obesity, as people get older, or of course, very poor control of diabetes or previous MI. So here is classification of people with type 1 diabetes, whether they have albuminuria or not, and clearly those who have proteinuria have higher risks of cardiovascular events as well as higher cardiovascular mortality. Finally, apart from diabetes, there's one other group of people who have very high risk that come into this very high risk, extreme risk category, and that is people who have familial hypercholesterolemia. So how do you make the diagnosis? And there's some diagnostic tools which, quite honestly, we don't use. Or you look at people who have very high LDL levels, so premature cardiovascular disease and an LDL more than 190. You don't need any further testing. These people clearly need aggressive management. We don't do genetic testing, it's done in some specialized centers, but the cost of it and the lack of payer coverage for this is a problem. So, how do we screen? The screening recommendation is to do a fasting lipid profile and then focus on the LDL and HDL cholesterol. And as Krishna pointed out, HDL is a very good indicator of risk. Targeting HDL may be a problem. Recently, there's been increasing emphasis on going beyond LDL. How do you identify a patient whose LDL is close to goal or maybe even at goal, who's at further risk? And in the past, we've used HDL, triglycerides, we're still using that a lot of the time, but a very simple calculation gives you the non-HDL. You can also use ApoB, but it's much more expensive. And the advantage of ApoB and non-HDL cholesterol is your patient doesn't need to be fasting. So patients who come in the afternoon, to tell them to come back and do a fasting lipid profile can be challenging. So you can just do these tests at one visit and evaluate your patient accordingly. So I mentioned some of these, and here are the recommendations from ACE on additional screening tests, current carotid calcification. You have access to it, HSCRP. I became very popular, but seems to be a little out of favor right now. It does give you some additional risk, but very often it's associated with obesity and insulin resistance, which you are identifying anyway. PLA2 is not being used very much, neither is carotid intermediate thickness. Homocysteine has been an interest of mine for a number of years. It is associated with vitamin deficiency and renal disease. The problem with homocysteine is that treatment of the high homocysteine with high-dose vitamins has been disappointing so far, although we're just setting up a new trial to look at it. I might mention it briefly tomorrow. Another area that there has been some controversy in the past has been whether we should give special consideration to women in terms of cardiovascular risk evaluation. And the answer is yes, except those with diabetes. So women with diabetes have just the same risk. The advantages of estrogen are eliminated by the presence of diabetes. We also need to consider secondary dyslipidemia, so things like hypothyroidism, nephrotic syndrome, renal disease, etc. become very important. So now we've identified risk. How are we going to go about managing that? And many of the subsequent slides have been covered by our other speakers earlier, and I will not spend too much time on the individual therapies that you have heard about. What we clearly know is that very low LDL is associated with very high risk. So how about lowering LDL beyond what we achieved before? We now have data to support that concept. The first of these comes from the IMPROVE trial, where people who had an LDL that was managed, reasonable LDL managed on a statin, were randomized to receive ezetimibe plus simvastatin or simvastatin alone, and then followed up for a period of 6 years. And there was a statistically significant reduction in events, although the absolute reduction is relatively small. And part of that relates to the fact that the LDL lowering wasn't very great with ezetimibe. The mean LDL on follow-up was 53, whereas in the control group was 69. Now, 69 is not a bad LDL in terms of, for most of us who've been practicing for the last few years. And going down to 53 did give a benefit. One additional bit of data that's very important in this context is what happened to people with diabetes. And when you look at it that way, the subgroup analysis shows that almost all this benefit with ezetimibe occurred in the diabetics, and very little benefit in the non-diabetics. Now that may be because these were the people who had the highest risk, that you have greater risk lowering, but this combination could be useful in people with diabetes who are in the high risk, very high risk or the extreme risk category, and it's less expensive than it used to be, so it's gaining in popularity as we get newer, more expensive drugs. So here's the subgroup analysis in the proving, as I pointed out, people with diabetes got the greatest benefit. So another new trial is with the PCSK9 evolocumab, and we're going to have a separate lecture on PCSK9 inhibitors, so I'm not going to spend much time on it. But the important thing is the tremendous reduction you can get. So we started this trial, all patients were on a statin, and with placebo, they remained static between 80 and 90, and came down to an LDL of 30 with evolocumab. And there are a number of PCSK9 studies now, people looking at things, questions that have been asked earlier about cognitive function, development of diabetes, etc. It doesn't appear to be very harmful to lower LDL down below 40. And when you look at the benefit, the endpoint shows statistically significant reduction in the hazard for the primary efficacy, which is MACE, as well as this key secondary endpoint as well. Now, there was some disappointment that the individual reduction in cardiovascular mortality did not occur, and some of this relates to the fact that this is a very, very expensive treatment. So there are overall statistically significant improvement, reduction in relative risk, and one of the things I want to emphasize to you as we discuss tomorrow when we talk about cardiovascular outcome trials, is also look at absolute risk reduction and not just at relative risk, because when you have a large number of patients, you can get something that's statistically significant with a very small reduction in absolute risk, and that raises the issue of cost effectiveness of this type of therapy. So, what goal should we go based on this kind of evidence? For individuals at low risk factors, having an LDL that's less than 130 is recommended. For those at modest risk who have a 10-year risk of a heart attack of less than 10%, an LDL of less than 100 may be appropriate. For those who have high risk, and this applies to many of our patients with diabetes, over the long term, if their risk, 10-year risk is 10 to 20%, a level below 100 may be appropriate. But as you get higher in the risk, and their 10-year risk is greater than 20%, the LDL goal should be less than 7. What is new is the thinking around this extreme risk group, people who are continuing to get cardiovascular events, even if they are minor events, because recurrent events could lead to death, but much more important, at least in our practice, is that they lead to the loss of cardiac muscle and heart failure, which is a very expensive condition to treat. And if you can prevent that, it might end up being cost effective. So people like that, the goal that has been recommended in the new guidelines is less than 55. There's going to be a lot of controversy about it. I'm not sure if this is based on the proven data. We did not have data from the evolocumab study when this was written. You're going to see more PCSK9 trials coming out and, with their results. It's quite possible that we might go lower than that in very selected individuals. So an LDL goal for many people less than 100, in younger children and people below the age of 40, is considered to be safe if they've got additional things like diabetes and obesity. Now, what about the other treatment goals? You've heard very nice presentation from Krishna on HDL, but raising HDL is somewhat problematic. Except for one thing, I want to bring up that, disagree with Krishna that there is no evidence on raising HDL. There is. There's a study called the IDEC trial, and the HIC stands for HDL intervention trial. So people were selected for this trial because they had a low HDL and they were randomized to gemfibrozil or placebo before the era of statins. And it was there was a significant reduction in events. So that was a very good result. And I still use gemfibrozil for people who are statin intolerant because of that study result. And the second thing, although we don't consider it an HDL raising drug, it does have the effect, and that's pioglitazone, which is effective to some degree in the proactive trial, but clearly in the IDEC study, in patients selected because they had insulin resistance, and most insulin resistant people have high HDL. The second treatment goal is the non-HDL. Where should we go? For most individuals, the simplest way to look at and calculate their goal is to take 30 milligrams higher than your LDL goal. So if your LDL goal is 70, you go to 100. If your LDL goal is 55, you go to 85. If your LDL goal is 130, it should be 160. So it's relatively easy to remember. It's still not acceptable and popular, as was said earlier. It should be a simple matter of the lab calculating this result and putting it out there. There are goals for ApoB. I think they're not very widely used, and I won't spend much more time, but we can discuss that later. Now, what about the goal for triglyceride? Dr. Shah mentioned 204. In the ADA guideline, also it remains at 150. I disagree with that, but these are consensus statements, and everybody came to that conclusion. The results of triglyceride lowering are very, very disappointing on top of statin. And it's very clear that we're going to use statins almost exclusively in all our patients unless they're intolerant. And mostly higher dose statins, higher potency statins in people with diabetes. What do we do with triglycerides? And I don't think we have a very clear answer, and I look forward to further discussion of that later on. So here is a summary of the LDL treatment goals in these patients: less than 55 for extreme risk, non-HDL less than 80, ApoB less than 70, and the rest are fairly straightforward. So what about triglyceride level? The goal in the guidelines says less than 150. Getting there would require you to use fibrate or niacin, and that's not been shown to be beneficial in trials. So, you've covered a lot of things that on the subsequent slides, so I won't spend time on them. I'd rather that we have a discussion on things like this, of some of the therapies, combinations of statin and fibrates we discussed. Something that wasn't discussed was omega-3 fish oil that has been tried so far, disappointing in people with diabetes. It's often forgotten that the Origin trial and an omega-3 arm, that people who dispute some of those results. But one of the problems with giving high doses of fish oil is that it actually raises the LDL cholesterol and makes it harder to treat the LDL. PCSK9 I'm going to skip over because we have another talk coming up about that. So LDL remains the major treatment, and we know that a moderate reduction of LDL, 20%, has a benefit. If we increase it further, we keep getting incremental benefit, but there comes a point where patients keep getting side effects and you have to discontinue. So here's a list of the statins. The atorvastatin and rosuvastatin are considered a high-intensity statin. There's been some interest recently of pitavastatin, partly because it doesn't change blood glucose, at least in some of the studies. However, the change in blood glucose that has been reported is very, very small. I don't think it's that important. So, PCSK9 inhibitors, there are two on the market in the United States right now, alirocumab and evolocumab. The alirocumab outcome trial should be available in about 6 months. They're given by injection, usually every 2 weeks. But the problem is a very high cost and very few insurance companies pay for it. So we have to see how this evolves. Following the results of the Fourier trial, I understand that Amgen has reduced its price a little bit. So I think we'll have to have further discussions on what the value of this treatment is, or maybe select our patients very carefully so that those who need it the most get the appropriate therapy. Here's a summary of the fibrates, and we've already discussed that, so I'll skip over that. So I'm going to stop there, and we can have some discussion here.
We will have it at the end, but your classification of the guideline has 3 levels of high risk. How clinician will take it. You can answer during question answer. We thank Professor Fonseca, ex-ADA president, and we finished with the final talk